Kala-azar is the second largest parasitic killer in the world after malaria. Most Ugandans are unaware of this disease that health experts regard as one of the most dangerous neglected tropical diseases. In Uganda, the disease was first reported in the northeastern part of the country in the 1950s. Decades later, it kept afflicting the people of Karamoja region, especially the Pokot in Amudat district.
It's an infection which is transmitted by a sandfly. These sandflies live in dry places like this one, in Kenya, North Pokot region, Ethiopia, Sudan, and Somalia. Most of the Kala-azar actually is found in India.
Dr. Patrick Sagaki, the medical superintendent of Amudat Hospital, is the only government doctor in the district. He says Kala-azar is hard to diagnose because many health workers have no experience with it.
We suspect a patient having Kala-azar if he comes to our unit and gives a history of having been in an endemic place, history of fever of 2 or more weeks, a splenomegaly or loss of weight.
The splenomegaly is the spleen, enlarged spleen. The spleen grows big on the side of the left-hand side. It grows big. Actually, on even touch like this, you will feel all the stomach covers it.
And it suppresses the bone marrow. So you find the red blood cells are depressed, so the patient has anemia, lacks blood. White blood cells are reduced, so you find the patient having other infections, co-infections. Platelets are reduced, so you find the patient having bleeding tendencies.
The Kala-azar department requires huge quantities of blood to treat patients, but the blood is always in short supply. The medics have resorted to getting it from either Mbale or Kampala, which are hundreds of kilometers away.
And it's one of the things which costs us a lot because you have to transport someone, you give facilitation for sleeping out, and then now of course you passed our roads, so you see how they are. We don't have a blood transfusion center in the region as yet.
According to the hospital administrator, the health team has to go to the villages to look for the sick.
They come the way they are. Even when you're taking them back, they should feed from different posts. You're taking them back before they start, because these are people who are mobile in their communities.
But all the same, drugs for neglected diseases has been supporting us in all this. And of recent, they bought for us a new car.
Amudat Hospital is the only treatment center for Kala-azar in the whole country. They take on patients from the Karamoja region, where the sandfly is mostly found. In a year, they can see about 250 patients. Some, however, also come from Kenya, which is just across.
We now try to support some other business centers like Matany with some rapid test kits. We used to give Moroto Hospital and some health units. But because of scarcity of test kits, we cannot afford now to give all the other health units.
The hospital has also been involved in drug trials to find cheap, safe and effective regimens. Because
most of the drugs have been so toxic. But we carried out clinical trials across the East Africa region, and WHO recommended the results of our research. Initially, we could give 31 days of sodium gluconate. Currently, we are giving 17 days of paromycin and sodium gluconate. Plans to start a research for an oral drug are underway. It's called miltefosine, the only oral drug so far for visceral leishmaniasis. The other name for Kala-azar actually is visceral leishmaniasis. That's the real medical name. Kala-azar is an Indian name, meaning black fever.
Treatment, however, varies according to the demographics of the patient.
Right now, we're using SSG paromycin, our first-line treatment, which is for 17 days. Each day, you get 2 injections. Then, after realizing for you are pregnant, we give you the second-line treatment. If you are a very young child who cannot withstand these injections because they are very tough, if you are very weak, you are malnourished, the buttocks almost are not there, there's no way you can inject. You have to give to the second-line treatment. And then the very extreme old ages.
What are the cure rates, really? About 98% of patients get cured.
We may lose like 1 patient or 2 in a year.
Most patients come when severely malnourished, especially the children. Unfortunately, due to the poor diagnosis, most people are often treated for malaria.
It's grave, it's dangerous for child. We will have a child with anemia, with a big spleen.
Dr. Mohamed Koun from Tunisia says his country suffers mostly from one of 3 types of leishmaniasis, known as cutaneous.
You could have 10, 20 scars in the body. You have a lot of disfigurement face form. It's not socially accepted, and there is so discrimination about this problem.
He says the cutaneous and the mucocutaneous types are easily identifiable. Robert Oseno, an answer the Kala-azar ward at Amudat Hospital, says the majority of the locals are ignorant of the disease and think it's caused by witchcraft. They resort to crude methods of treatment.
You find somebody at the side of the spleen where the spleen is big. After they're palpating, they also try to burn them with fire. That they are what? They are treating it. That if you burn there, it can go and reduce. They get fire, put you there.
According to WHO, leishmaniasis, including all three types, is linked to environmental changes, including deforestation, building of dams, irrigation schemes and urbanization.
We will trying to do some things to change the irrigation schedule and the irrigation techniques in order to avoid the contact between human and sunflower.
About 1.3 million new cases and up to 30,000 deaths occur annually all over the world. There are patients who develop post-Kala-azar dermal leishmaniasis, which manifests as a rash on the face, upper arms and other body parts. In East Africa, 50% get this after 6 months to 1 year or more of being cured. These, according to WHO, are a potential source of infection. Some of the risk factors to look out for are poor housing and domestic sanitary conditions, which may increase the sandfly breeding and resting places. Crowded houses, which are an opportunity for a blood meal, sleeping outside or on the ground, which are common in most homes in Karamoja, are other risk factors. The vector can be controlled by using insecticide-treated bed nets, spraying, environmental management and personal protection. Florence Nalimba, NTV Namudat,